Started recording.
Lovely, thank you very much. It's 1:30, so I shall make a start. Welcome everybody to the October Primary Care Commissioning Committee this afternoon. Just as a reminder, the meeting is going to be recorded and it will be put on the CCG website afterwards. So I'd be grateful if people, if they can, turn on their camera. I know some have various issues, including bandwidth, which I understand. Just makes my life a bit easier if I'm seeing people rather than blank screens. Moving on to the agenda, there weren't any chairs action last month. Apologies we have from Kathy Branson, Jude Browler, James Foster, Carla Gosling, Michael Dennis, and Kath Byford. On to the declarations of interest. Are there any declarations relevant to the agenda this afternoon? And also, can I just remind people to keep their registers up to date? And also, once the old declarations that are no longer valid stays on your register in public for 6 months, and then it's kept in the CCG records, just in case people wonder why they changed it and it's still there. There's nothing there. I will move on to the minutes of the last meeting. Are there any corrections in terms of factual or accuracy, or any matters arising anybody wants to raise that's not covered in the agenda? I just had a couple. One, they're very minor. One is on page 9 of the minutes, page 10 of the pack, under number 9, locally commissioned service. It's a question, really. It says on the minutes, it says the end date is end of April 2022. I just wondered whether we meant March 2022 for implementation in April.
Yes, I think that's right, Doris. I wasn't there myself, but that sounds...
Just change that.
Accurate.
And I think there was a minor typo somewhere. I'm searching for it. Oh, on page 9 of the pack, it's just in the second paragraph. There's a extra S on was. That was all that I spotted. Is there anything else from anybody? No, and there's no matters arising. So I will move on. So the minutes are approved subject to those amendments, and I'll move on to the action log. There's a couple of red items. One we know is the terms of reference that where it's with NHS England, and the other item is the Cottishall CQC report. And I think we're just waiting for an update from Carl on that. If Sarah could chase after the meeting, that would be good. There are a number of items which are closing, which is 63, 72, 74, 76 and 77. And then I think there'll be a couple of items will be closed post the meeting in terms of 75, 78 and 79, because they're being covered on the agenda, I think, today. So are there any questions or comments on the action log? Sadie?
Thank you. Apologies as I wasn't at the last meeting, but the item 75, which was the risk around the blood bottles, that is a risk that's recorded and monitored through the Quality and Performance Committee. And I note that there was a request that this should be considered to go on the governing body assurance framework, but also a question mark about adding it to our risk register as well. I know Karen's got a hand up, but we did seek advice from the experts on the GBAF about this, and we're advised that it really should stay just on one committee risk register, which is the one it's on currently, because it's a risk that's wider than primary care. I'll stop talking and let Karen come in, if that's okay.
Yep, that's fine.
Thank you, Doris. Thank you, Sadie. That's correct. It needs to remain on the quality and performance register because it is broader than primary care. It's also an improving situation, and I'm quite happy to share the risk with the committee if you wish to have sight of it, as it's updated monthly, rather than add it to another risk register. So if you would like to see that or have access to that particular risk, I'm very happy to facilitate that.
I mean, I'm happy for it to be on the quality committee, and seeing that Kathy is also a member of this committee, I'm sure she will raise the red flag if we need to know. Brilliant, thank you very much. So we can close that one as well. So that, is there anything else on the action log? No, thank you. On to the forward planner.
Apologies, sorry, Doris.
Sorry,
I missed the window to raise my hand.
You need to be quick.
Yeah, thank you. I think there's an action for me around the annual health checks for learning disabilities in the action log. And there was a query from colleagues at the last meeting around what are we doing about annual health checks for individuals that are in inpatient services, and also what is our ambition as a local system on the annual health checks. So I'll start with our ambition. Absolutely 100% or more. We would like every patient with a learning disability to be offered an annual health checks, and not only that, to be followed through. And that commitment is from all the localities. So that is one. But we also have a national target, which is 75%. And that target has increased each year. You would probably know that last year we were around 69% in terms of, that was the national target. Now it's gone to 75%. So I expect that target to continue to be stretched. But also I do realize that we have to build some tolerances within this, because there will be individuals or families that would make a decision that they don't want to have annual health checks done. Not to say it's right, but actually if we build that in our targets, it will help to manage. And within that also, we do have some tolerances that would be to do with some of the coding issues, and also just some rigidity that we find sometimes in our systems. So for example, if we look at Noonan's disease, it's coded as learning disabilities. So that tolerance that the national team gives us, it actually helps us to manage some of those anomalies that we find. The second bit, which is about trying to capture everyone, including those that are in inpatient services, that is still an ongoing piece of work, because the CQRS system does not tell us where patients are. So we are working through with colleagues in the BI, and also contacting providers to just get to the bottom of that, to understand whether we are capturing every individual. So I'll be happy to update at some point in these meetings once we've got a breakthrough on that. I hope that closes that action for me.
Thank you, Shepard. That's helpful. John?
It's a separate point, but I think thank you, Shepard, because I raised that question last time about the ambition. But just to add as well, action 79 we can close. We've discharged that offline, so that one can close too.
Thank you. We look forward to further updates, Shepard, no doubt from you, on the learning disability health checks. So I'll move on to the forward planner. A couple of reds on there in terms of the biannual report on delegation and the learning disability report. So is there anything you want to add, Sadie?
No, not to the note that I've included there to explain.
Right. Thank you. On to the risk register, which is for noting. Sadie, I think it's got your name against it.
Thank you, Doris. I think what I will do is the same as previous months, where I will just focus on the red risks today, but obviously I'm very happy to answer or try and answer any queries on the others. So we've got 3 red risks. Shepherd's just talked a little bit about learning disability health checks, and you'll see from the update in the risk register that having set up the task and finish group now, the discussions are becoming more targeted within the localities where I think there's the most work to be done, and I think obviously we were due to have an update report this month, but the update will say that it's probably worth letting some of that work happen before we bring the update, hence the decision to defer it. On the next red risk, which is PC9, the hypnotics and anxiolytics, unfortunately we haven't got anybody from meds here today due to sickness, but you'll see from the update that the team is really beginning to get back to some of the business as usual stuff that they had to pause before. And while it's a very tiny movement, there is a slight improvement in our performance vis-a-vis everybody else. So we've gone from the 99th to the 98th percentile, but you will see from the graph that's included in the medicines management report that it is a nice downward trend. It's just that everybody else is going downwards as well. So our overall position hasn't really changed a huge amount. PC11 is the risk around the primary and secondary care interface, and there is a paper on the agenda on that later today. This has moved in that the first meeting of the new interface group is happening next week. The agenda is due to go out today, and the first meeting will be used to agree the priorities for that group and when they're going to come. So as well as agreeing the terms of reference and what have you. So we should be able to give you an update on that at the next committee meeting as well. So I'll just pause there in case anybody has any questions either on those 3 or any others on the report.
Are there any questions from anybody? Sadie? Hein.
Yeah, thanks, Sadie. A few comments. Risk 15, when I read the later agenda item, it had some worrying signals around, can we achieve the deliverables under these Wave 4B primary care hubs? So maybe when we get to the agenda item, that warrants an update in the next time. A second comment that's more for information is it struck me already last time. It's a very concentrated risk dashboard, so everything is in one big blob visually, and it's, for instance, quite a striking difference with the one for the governing body. So more an encouragement, can we not distinguish more between what is really pressing versus maybe more under control? More a general comment. And lastly, a request building on the comment made earlier about the tubes, is that I fully agree that it should only be in one risk register, but it might be good in a cover note to say actually there are a few other risks relevant to primary care. For instance, in the governing body, there's primary care pressures, just to note that some of these things have attention in other committees as well, just to cross-section. Those are my comments. Thanks.
Thank you, Hein.
John?
Yeah, thank you. I was just going to circle back to the LD health checks issue again. Just recognise what Sadie's said, but recognising it's a red risk on our risk register. And the previous item suggested it was on the forward plan for a 6-month review. It feels like it should be much more frequent than that. So this committee's got more up-to-date information, more regular information on progress, but also, I suppose, issues that might be coming out of the health checks. Clearly, we're very aware of the recent events around Causton Park and the need, therefore, to have a particular focus on patients with learning disabilities and autism. So it feels like something that we ought to have an active overview of, I think, at this committee on a more regular basis.
Thanks, John. I'm sure Sadie and the team can work something out on that one to come back a bit more regularly. Hein, did you want to come back in?
No, sorry, I was trying to get my dog at a safe distance.
Shepherd?
Thank you, Doris, and thank you, John, for that. And it's really helpful. It will keep us on our toes, definitely. I just wanted to assure members that I'm looking at a review at the end of quarter 3 to review the position, whether we are still in red or not. But there's a strong indication from all the localities that we are likely to deliver to the commitment. I think 4 of the 5 localities are reasonably in a strong standing to hit the national target. The remaining locality is quite challenged. It's tight, but at this stage, with everything that is being done, we may be able, we are close, but it's going to be tight. But there's a lot of work that we would need to do to be able to have an overall improvement across the system, but I'm quite positive.
Thank you, Shepherd. I just had a thought in terms of some of the updates that are shown in red are now a couple of months old. So if we can just maybe tidy it up and do a review for the next iteration, just to make it slightly easier for us to wade through. No, read diligently. Thank you. If there's no other questions on the risk register, I will move to the update on the primary care. Are you taking this or Mark? I think Mark's not with us at the moment. He's on a call.
Yeah, he's slightly delayed, so I'm very happy to take it for him, if that would be helpful, Doris.
Yes, please.
Just quickly refresh myself on it. So I'm going to assume that everybody's read the update. We're focusing on 3 main things, which feel very live for general practice, I think, and the teams working with them. So you'll be very well aware of the some of the difficult media coverage. I think it's this was raised in the annual general meeting. Sorry for the banging. As well, and I think real concern about the impact on general practice from this kind of negative overall experience for them, I would say. So I think both the LMC is tackling this and taking it forward, have been working with both health watches, and our own team are, as you know, implementing a sustained comms campaign, which you will have all seen last month. And I know that the LMC has some comments on that, which are being shared directly with comms colleagues. In terms of the next phase of the COVID vaccination programme, we're moving into boosters now. we've had 16 of the 17 PCNs sign up for it. We're almost there with all the new paperwork that has to happen to approve this. It's always slightly different to the last version. So we're going through that process again, and that's requiring primary care networks to agree their collaborative arrangements around this. So it's not, you know, they need to be able to identify quite a bit of time, which is why we're not quite there with everybody yet. But we're really delighted with the progress we're being made, with the commitment from primary care at a time when they've never been busier, as well as our other partners that are working to deliver that programme. And then finally, there is an update there on the interpreting services, and I won't go into that in any detail because that's covered in Fiona's paper on access later on in the agenda. But as always, we'll continue to bring a regular update on this, but if there are any particular items that members think they would like covered, then please do let us know in between meetings and we can look to include that as appropriate. Thank you.
Thank you, Sadie. Are there any questions or comments for Sadie? Tracy?
Yeah, just quickly, really, in respect to the vaccination programme. So I attend a regional inequalities task force on the vaccination. There seems to be some early indication regionally and nationally that kind of the boosted uptake is quite slow so far. And I realise that for some people there are challenges with access to that particularly. We're not having walk-ins as we were before with our phase 1 and phase 2. So just thinking, have we got any early indications that there's any kind of, you know, things that we need to be concerned about, or perhaps addressing this early part of it? Because just picking up from what the kind of regional and national kind of awareness has been so far.
Thanks, Tracy. I think it looks similar picture in Norfolk and Waveney. It does look like it's a little bit of a slow start. Certainly the national booking sites are starting to, well, they've got their capacity available and people are booking in 4 weeks ahead. So, and I think the other thing that is a bit of a limiting factor is that until you have reached that 6-month interval, you can't even book your appointment if you go via the national booking system. So that might be a bit slow. We have got the profiles, we know who's eligible and when, and we can monitor our numbers against that. But you are right, it is a bit of a slow start, and certainly the primary care networks, they can't really start jabbing until they've done all their paperwork. So that, you know, that's quite important for them as well. And they will be focusing to start with on their most vulnerable patients that they did first in the last campaign, so care home residents, housebound, and we know that that takes a lot longer than seeing people all in one place on site.
Thanks, Sadie. Are letters going out from the PCN sort of like last time, or is everybody expected to book through the national system? I wonder whether that's part of the confusion for some people.
Yeah, I mean, one of the national letters are going out, but the national letter gives people the option to wait for to be contacted by their local primary care service. That obviously causes a bit of an issue in the one area that isn't covered by a primary care service, and we are working with that PCN to make sure that the appropriate comms happen. But certainly in that case, we have covered off all of their housebound and care home residents through neighbouring primary care networks. But yes, potentially we've got people who are sitting tight waiting to be contacted because that would be their preference.
Thank you. Shepherd?
Sorry, I didn't raise my hand. Sorry, Doris.
Sorry, it was a legacy.
Rosemary's hand up.
Rosemary?
Sorry, Doris, just to address your question, I mean, from a primary care perspective, we are sending out text messages like we did before for the boosters when the time is right. So in other words, when they've reached their 6 months after the second one, then they will receive a text message from us. I mean, I must say, just from a personal point of view, but just speaking about the national hub, certainly because I was one of the people that had my vaccination very early, and when I got the letter about the national hubs, there was an awful lot of availability through the national hubs, which was good, and other places coming on stream I noticed which weren't on stream for the first and second boosters, some local pharmacists, so that was good, you know, some alternatives. I think that may be one of the issues with us. I think there's just not quite the enthusiasm there for the boosters as there was for the first and second. But certainly our PCM will be calling people for boosters in the way that we called them for the first and seconds when they're eligible after their 6 months.
Thanks, Rosemary. Maybe when the weather gets a bit colder, there's more incentive to come out and get it done. But I think things will hopefully pick up. So we can all but encourage people. Mel.
Hello, I just wanted to comment on that. I think it would be helpful to understand how patients who are in perhaps harder to reach groups, those who are maybe the elderly who had their 2 vaccines earlier, who perhaps, you know, they are the same group that maybe don't have access to text messaging. How are we ensuring that they are invited? I mean, certainly we've heard personal stories within the LMC of people not being contacted for flu jabs and for COVID boosters because, you know, they haven't got smartphones, so they're not receiving these text messages. And our understanding is that the national online booking system is only for healthcare workers and frontline healthcare and social workers, not the general public. And that certainly doesn't appear to be a message that's known out there, that they can just go online. So I just wondered if there was a bit more PR that could be done around that, perhaps by the CCG, to get that out to patients locally.
Rosemary, did you want to come in? You're muted. Yeah.
Apologies. As far as the national hubs go, you can certainly book on those hubs if you're due. My husband had his call through and he went to the national hub, and he's not a health worker. He just happens to be over 70, so certainly he had his done through the national hub. And for those patients that don't have smartphones, we telephone them or we make contact by letter.
Thanks, Rosemary. There's probably no harm in doing some sort of communication piece, just to be clear, so the public are clear what's happening, especially if there's a wee bit of confusion out there. Thank you. If there's no other questions, I'll move on to the next item on the agenda. I assume that's a legacy hand, Mel.
I have actually put it down. So
sorry,
maybe there's a delay in the system somewhere.
It's probably a bit slow. I need to get my hamster to run a bit faster. Onto the locally commissioned service paper, which I think came separately from the pack because it arrived just slightly later. I see that Gina has joined us. Welcome, and over to you.
Thank you for having me. Usually I would take a paper as read, but due to the detail involved here, I did wonder if it's worth me just going through and highlighting the key points. I shall try and keep it relevant and not bore you to tears. So we've talked many times about the LCS review, where we've got to date and the progress that's being made. And one of the things that's kind of really come to the fore is the need that as we're working at speed across multiple teams and areas, we need to have a really clear idea of what we're doing, how we're doing it, and when we're doing it. So we've gone back to basics for this one. So we're looking, clearly we've created, identified the stakeholders as we're picked up here. We're looking at different project teams. The LMC are very much to be involved and are our critical friend, is the phrase we are using. The clinical exec will carry the can as far as approving the clinical specification goes, bearing in mind that we are going to be clinically led in order to be able to link into our 6 key principles. Clearly, they will not have the financial information because there's a clear conflict of interest, so that will be separately, but they will very much be responsible for agreeing what we deliver and how we deliver it. Yourselves as PCCC will continue to approve the process, and we are today seeking approval on this process that we're undertaking, and then obviously EMT will have the ultimate sign-off. We have an overall programme board, clear accountability for the delivery of the review, to keep it on time, in budget and of good quality, and to basically do the problem solving as we go through. As we've identified many times, the timescale is challenging. We've talked previously about the number of LCSs currently available. So there's 38 LCSs that we are looking at within scope, and there was proposal initially to drop it down into 10 groups. This was an early option. We were going to look into it under 10 project teams to try and keep things feasible. And there was a discussion at some point about actually making it into 10 LCSs in order to be able to group them. When shared with the LMC, they quite rightly came back with feedback that they didn't think practices would like this approach other than where there's precedent already set. So, for example, where we have the treatment room service, where it's already a precedent and all the long-term conditions, then they will stay as groups, but everything else will break down into individual components, which provides us at the moment with 16 potential service lines. And I'm going to reinforce the word potential here because clearly as we undertake the service redesign and we look at what's currently being offered and what is being sought, then these may well change. So please do not think that we'll end up with 16 specific services, because that's the whole point of the review. In order to keep each one targeted, and again, this does link in to the LMC feedback, which will come through later on, is that we're really clear that what we deliver has got to be effective and efficient and what's in the best interest for our patients and our practices. So we are looking at the overall 38 and saying actually within them, let's look at service stratification. Is it important to our patients? Is it important to our practices? Is it important to the CCG? And we'd love the fact that they will correlate, but sometimes we will know that they don't. So we're going through and prioritising these to make sure that we are not missing anything. We're looking at service specifications that are currently in play. The level of activity. Now, in order to be able to go through and gauge activity, we all appreciate that the pandemic year has not been typical, but we also appreciate that we're unlikely to return to the pre-pandemic volumes. So in order to be able to go through and look at this piece of work appropriately, we are going to be taking the 1920 volumes as the last normal, she says inverted commas, period of data that we have, and then looking at it. We will be applying an uplift on there because obviously patient numbers have increased over the last 2 years, but we'll also then be sanity checking against the returns we're getting currently for Q2 and Q3 of the LCS has been provided this year in order to be able to sanity check what's happening. We're going through and agreeing a basis of funding for each of the service lines, looking at whether or not we deliver an item service, whether it's on a block contract or cost and volume contract. And we'll be looking at the actual service costing. Now, we've said before that one of the key principles of the LCS review is to make sure that we reinvest the envelope into primary care. This is not about saving money. This is about enabling our services to be equitable across the patch to all our patients and to provide resilience and stability to primary care. So we have agreed and worked with the LMC, and they've been very kindly shared the Surrey and Sussex LMC costing tool, which is a very transparent basis of where we cost up a service based on actual delivery costs. So that's cost of individual clinical levels, it's looking at estates, it looks at training requirements, it looks at equipment. And it goes through and is applies on costs, project management costs, the work. So it's something that we've agreed to utilise. And then clearly the proposal at the end of this process will be up for discussion. And when we talk about a proposal for discussion, we're talking about going through a clear achievement process. So the project team itself, we're going through and looking at specifications clinically led by their clinicians. And we're ensuring that those project teams, they are having nursings on there, we've got GPs on there, we have other healthcare professionals, pharmacists and the works, as appropriate for that service line to make sure that we get the best available. And that's been compared against NICE guidelines to make sure that what we are asking to do isn't just what we fancy. It will then come through and work with us as a programme team to go through and do the costing and also to agree the reporting requirements. Now, one of the things that's been happening in primary care for a number of years is that we quite often ask them to create a service or a report that they then have to jump through hoops in order to be able to present the activity data at the other end. We're working at this point very much directly with the clinical systems to make sure what we ask them to monitor, what we ask them to report back on is something that's easy, reduces the bureaucracy, again back to our 6 key principles, so that what we are asking them to do means they can concentrate on the clinical delivery and not concentrate on the reporting element. The draft service specs will go to CEC, which is our Clinical Executive Committee, because then it's a wider pool of clinicians in order to be able to approve and agree what it is we're asking to do. And at that point, we will be sharing it also with the LMC for consultation. The Clinical Executive Committee will not get funding details because they are clearly conflict of interest. They were members of general practice, but the LMC will get funding details around the cost envelope. And then it comes through to EMT and yourselves as PCCC. Now, we are, as I've mentioned, probably twice so far, up against quite challenging timescales, and we are against quite a challenging financial envelope. And in order to be able to do this, we are proposing that we break down the 38 into the 16 service lines at the moment and phasing them so that we can manage our workloads appropriately. And the phasing means that we'll be going through submitting papers to the Clinical Executive Committee on a phased basis, depending on the stage of that project line at the moment. So the anticipation is that everything will go through the clinical execs by the end of November in order to come back to PCCC in December. And we're still on target at the moment to come out to practices in January as discussed. So what have we done to date? So we created and convened the 10 project teams. Everything's got clinician led. We've done the initial meetings and we've also undertaken an initial review of all the services currently in place. We've looked at consulted with the LMC, and we've also assimilated all the activity data as we currently have. So we have a really good foundation block within the last month of the work that we are taking. And if we carry on this a tempo and the amount of work's being assimilated, then I'm confident we will be able to deliver. I've detailed in the report, in the paper, the feedback we've had from the LMC. We posed 3 key questions as part of our consultation. The first key question was to discuss the commissioning under a group approach. As was established, we said that it's not been supported except where there's already a precedent set. They would very much support the approach of reviewing specifications in the services in line of clinical priority and patient need, and the funding being calculated. So this ties in very much to the process we mentioned earlier on. We're looking at multiple years contracts where possible because we want to continue, as I go back to our 6 key principles on a constant basis, provide stability to general practice. So where we can, where a practice, where a service is stable, we'd like to offer it for a longer period of time. So we're looking at maybe 5 years for the standard services. And with those that are looking either on a pilot basis or we know it's going to change, then there'll be no shorter footprint. And the LMC absolutely support that as is clinically appropriate. And then one of the key principles is that we want our patients across Norfolk and Waveney to be able to consistently access these services. So although that we as a CCG acknowledge that it's a commissioning responsibility in order to be able to provide these services, and we cannot force our providers to provide them, the LMC are absolutely in agreement, as are I think many of our neighbouring practices, that we want our patients to have equity of services. There was a challenge from the LMC that we hadn't broken down, as we'd mentioned in our previous PCC paper, the actual financial envelope. And this is because we, within our process, agreed that actually what we've done historically in the past might not be relevant to what we want to do in the future. If we're going to go through and cost up our services fairly and transparently to our practices, then that's what we should be focusing on. So rather than spending the time going through and trying to break down historical data and analysis, we've said no, what we're going to do is we've committed the fact that we're reinvesting our cost envelope and we want to commit it and give it out in a way that's fair and transparent. So that is where the focus is, and that's why we've not detailed in this paper the financial breakdown. Clearly, we will be going through, as we use the costing tool as a programme, we will be monitoring that costing tool. The financial envelope is a financial envelope, and we will be adjusting what it is we need to deliver within that. And yes, the timescale is challenging. We are still on our commitment to have these live with general practice on the 1st of April 2022. And we all acknowledge the fact that that is a very steep timeline. But I'm sure that by working through collaboratively and fairly and involving primary care at the point where we're creating the services in order to make sure they're as effective and efficient as possible, I think is the way that we want to go in order to be able to meet this. So finally, the next steps, we're looking at agreeing with the LMC a joint communication. I think it's absolutely essential to our practices that there's lots of discussions underway at the moment about the fact that the review is taking place and people are nervous. They always are with change. And there's been an awful lot of change, let's face it, over the last year, 18 months. So I think it's absolutely essential that we agree fairly quickly a communication briefing and plan to practices so they know exactly what's going on, how it's going on. And the process we're undertaking, we are absolutely transparent. We are more than happy to share all the day steps we're looking at and the workloads with our practices so they have the confidence that what we are doing, we're doing thoroughly and we're doing fairly. So we'll also continue on the service redesign, and by the time we see you next month, we'll also have had a number of services gone through the Clinical Executive Committee for discussion. So that is my whistle-stop tour of the paper to date. Any comments or queries, please?
Mel, do you want to come in?
Yeah, unsurprisingly, the LMC do have some comments on this paper. First of all, in the culture of no surprise, I've been asked to feedback that the LMC would have liked to have had a conversation around some of the points that are raised in the paper. The first we've seen or heard of much of this was in the PCCC paper, so that's obviously problematic. On page 2, the reference to the programme with several key stakeholders. It's interesting to hear the CCG has started to use the terminology of "we're your critical friend," and we're more than happy to accept that, but we must point out that our actual role is to represent GPs and their practices, and that needs to be included. That is our main focus, and that's not actually included in the paper. Also on page 2, around the volume of service and the service lines. Again, we're still not clear what are included in the now 16 service lines. We haven't been able to have clarity on what's in scope and out of scope. The first paper that we received from the CCG in July had 43 service lines. The paper that was received by committee on the 21st of, or for the 21st of September meeting referenced there were 38 service lines, but only 31 were included in the table. We have consistently fed back to the CCG that our understanding is that there are more specifications, and where we've known of those, we have provided those to the CCG, and they don't appear to be included. So we feel this is still a real question mark about what services that are currently being provided by general practice are being included. So that's what I've been asked to feed back to you. We've also got a question mark around, I think it's on page 3, around the change in schedule and phasing due to committee meetings. That isn't a conversation that we've actually had, and I've been asked by our chair and vice chair to ask how that is proposing to work, because we don't actually have a committee meeting in December. So it would be helpful to understand the reference to our committee meetings in line with your phasing, because obviously we want to make sure that we are available. And then finally, in response to around the finances that are included in this paper, I think it's really important, and we've been asked feedback from both committee and from practices who are extremely concerned about not knowing what services may not continue from April. And we have consistently fed this back, and practices are extremely concerned because they know the funding pot is a limited funding pot, and yet services are looking to be increased across the locality. So if they're currently provided in one area, you may be expanding that across other localities. And what they don't understand is how that's going to be financed, and if they don't know what services are not going to continue from April, where they are employing staff directly to do that work, they are really concerned about redundancies. And one locality yesterday asked me to feedback specifically that they would now like redundancy training from the CCG. Because they don't have any information, and I completely understand the need for communication to come out from the CCG to practices, but I think we've been unable to allay their or answer their questions because we don't know, and so I think it's not at all clear. And yes, of course, we would like to reiterate finally that we do have concerns around the timescales. Our involvement in the consultation should have finished the end of this week.
Thank you, Mel. Would either Sadie or Gina like to take this up, answer some of Mel's points?
Yeah, I mean, there's a lot there, which I'm probably not going to be able to respond to every point. I hope you can hear me. Really sorry. Gina, can you just...
Sorry, we've lost you.
Happy to go first.
Yes, of course. Apologies. I know, Sadie, you've got background issues. Excuse me. So a couple of points, and I have tried to make some notes. There was an awful lot to go through. This is a work in progress. So first of all, if the LMC do have details of specifications that are not involved, please can they ping them across to me personally in order that I can review and find out whether or not they are in scope or out of scope. It is a challenging remit to work through, and we have been through quite a detailed view of what we are including, what we're not including, and there is reasons behind each of those components as to why we are including and not including. So we can always go into detail another time, and happy to have that conversation with the LMC. Communications, we are very keen to communicate to practices as soon as possible. We will be picking up a joint plan in order to do that, but if I had my way, coming from an operational practice background, I'd be out at every practice meeting talking to them every week, telling them what's going on and why and how, because I know how it feels to be on the other side, and that's certainly part of the discussion that we will be having going forward. The committee meetings tie in for the papers. That's very much down to the fact that we know that we want to work with the LMC in a proper consultation basis, and rather than doing on an ad hoc basis, which is kind of what we'd hoped initially, we understand the need to go through their committee meetings. So that is why that we are looking to phase them slightly differently. And you lucky people not having a meeting in December, I shall have that conversation because we will need a December meeting with the LMC. Perhaps I'm going to change sides. I hope I've covered most. Sadie, do you want to pick anything else up?
Try and say it really quickly. I think I note Mel's comments, and I think we all would prefer to be further on in this, and we all know why we're not, and it is not ideal. But what we are trying to do is reach the LMC has advised us that January is the absolute cutoff, and that is what we are aiming for. Has meant we've had to be really fleet of foot in terms of the progress that we're making as we cover issues to change things around slightly. Can't deny that the real. I think we are very keen to work together on this and have been throughout. And I think, you know, it sounds like we probably need to have a conversation outside of the committee meeting about how we can jointly achieve what we both seem to want, but haven't managed to land so far. Thank you.
John?
Yeah, just a couple of brief comments, if I may. I was going to say something similar to Sadie in terms of timescale. I think it's inevitable with this sort of process, isn't it, that there is a period where we're entering the unknown because we're reviewing it, but I think we need that tight timescale to keep focused on it. We've been trying to do this for some time, haven't we? So I think that's an inevitability about where we are at the moment. Fully support the paper. I suppose there's a question from the discussion that's just been had about maybe just being clear what is that ongoing engagement with the LMC, but I'm sure that will be there. the other comment I was going to make is obviously there are conflicts of interest around this virtual table in respect to this discussion, so we probably ought to just note that in terms of the discussion that we're having now, because obviously there are people employed by practices that are part of this meeting. But very supportive of the paper.
Thanks, John. Are there any other comments? Andrew?
Yeah, thank you. I was very pleased to hear in the initial introduction about how you're taking into account patients' views, but could you just very briefly outline how that's been done and what your understanding of patients' views are about this?
Thank you. So yes, due to the timescales involved, we are working alongside the service users of those services currently in establishment, in as much as we're looking at what we are doing currently and how we're achieving what we set out for initially. We are very aware that those services that are more patient outcomes, shall I say, rather than day-to-day. So when we look at phlebotomy, for example, your patient, your user involvement and your user experience will be very different to that from long-term condition management for those who have patients who are less stable in their respiratory, for example. So what we're going to be doing is looking at what we currently have, planning the design going forward, involving users where we can currently, but then very much building into the early days of those unstable services, i.e. those that aren't just a day-to-day provision, those touch points in order the fact that we can evolve the service over a 12-month period. So those where we know that they are not already being delivered and that we're not looking at, where we're looking at changing, then we will be building those touch points to make sure that by the time the following 12 months comes, then we can be improving that experience where necessary.
Hein?
Yeah, thanks, Doris. I know it's a very tight timeline, and as John said, it's important to see if we can reach it against the deadline. But my practical question is, what if this is delayed by 1 or 2 months? What is the real impact? Because sort of reading between the lines, it's a realistic possibility we may not achieve April 2022. So I'd like to understand what the practical implication is, because last thing I want is people sort of working crazy hours to achieve maybe not an entirely satisfactory product.
I'm going to pick up one point and then defer at one point, probably to John, bearing in mind Sadie's background issues. So the first point I'm going to pick up is the impact. Now, we have committed at the moment to providing the detailed service specifications by January to our practices in order that they can input commencing by April. Now, in all the years I've worked in general practice, we don't always get that 3-month buffer. And I think if there's any chance that there's any slippage happening at all, then that's where the nip will happen. But I'm absolutely committed to this process, having worked on both sides, that if we do not hit for any reason that January timeline, that we must bring general practice with us and tell them exactly what it is we're trying to do, how we're doing it, and what's at risk and what is going to be the impact, so that if there's any reason why we're still fine-tuning those elements at that point, then it's not a surprise to them when we come to February. But ultimately, our commitment at the moment is to deliver this in a way that is feasible and secure and transparent for patients, and that hits the target. John, did you want to pick up the impact if we don't hit them?
Not sure there's too much more to say, Gina. I suppose that this is clearly a local deadline that we've set ourselves to get this done, isn't it? And there would be ways of extending existing arrangements if necessary beyond April. But I think it's helpful to have that deadline to aim for, because it would avoid that transactional workload as well of having to kind of renew or raise new contracts and then update them again when we get this work done. So I think it's right to aim for this. But as Gina suggested there, come January time, that's probably the time to maybe take stock and say, are we still going to hit April, or do we need to have a review of that timescale? But it seems appropriate to me to keep going for April for now.
Yeah, well, thanks both.
Sadie, did you want to come in?
Yeah, if I may, I know Mel's hand was probably up before mine, but I just wanted to add that the LMC has asked us to hit January because of the time for mobilisation, and I think it's a really fair request of us. And if we think that at the moment not all practices provide all services, clearly, as one of our principles, we want consistent coverage. So it's within it. It also enables us to have time if we do have any issues to deal with, that we've got time to put alternative arrangements or negotiate different arrangements in place in each area before the April start date. So I think it's within everybody's interests, but recognising that it is very challenging, as we've said a number of times.
Thanks, Sadie. Mel, did you want to come back in, or was that a legacy hand?
No, I think I was just going to really say sort of what Sadie had said there. You know, part of this was built in not just to, you know, allow practices to have that opportunity where they were starting perhaps services that they hadn't delivered before, but obviously also if there are services that are not continuing, you know, there is notice periods, etc., for staff, and that will cause, you know, them additional communication issues with patients about services that might be stopping, and purely also to allow the CCG that time buffer so that it can go out if there are any issues, if there are any services that practices decide they're not going to sign up to. It gives the CCG the opportunity to look for alternative provision. So it's really a fail-safe, you know, to support the CCG and practices in ensuring that there is a smooth transition period to April 2022. But we fully appreciate, you know, that hasn't happened in the past, but it's not, we've never undertaken a review like this in the past.
Thanks, Mel. It's good to see there is some alignment in terms of ambition, and no doubt we will hear more as this project progress. If there are no more questions, I'm going to ask the voting members whether they're happy to approve the paper. Yeah, great. So we've got approval for that, Gina, and good luck with the work, and keep going. Look forward to seeing you again before long. Thank you. We'll move to item 9, which is access to primary care. It's over to you, Fiona.
Thank you. I will take the paper as read, but I just wanted to really highlight some points. We've started looking at how accessible practices and primary care is, I think as a result of the restoration of services which commenced in the summer this year. And it's clear that there are a number of actions that need to be taken, and this paper outlines some of those measures that we're looking at for both the short and medium term. It's already been alluded to that concerns around access, whether perceived or real challenges with accessing primary care services, are creating a small group of patients to manifest this with some challenging behaviour, which is perhaps unhelpful. I think the other side of this is the messages and how the news is being perceived in the media as well, and so that's an important aspect of how we manage our communications with patients. The other factor affecting access to primary care is actually the accessibility or otherwise of other services, and the interface between primary care and, for example, urgent and emergency care, mental health services. And changes in pathways in one part of the system may have indirect and unintended consequences in primary care. So looking at this issue, it's quite wide-reaching, and of course one of the key parts of this is ensuring that we have a a sustainable and resilient workforce as well. I've pulled together just a couple of slides summarising the GP appointments, and if I could just share my screen very briefly. You can see here, so this is the data from April 19 through to August 21. And you can see how appointment types have changed over that time. And in green, you can see the COVID vaccinations. And you can see the increase in those, and then the dropping off of that. But obviously, of course, we're getting likely to see that increasing again over the next few months. Below that is the summary of face-to-face appointments and the summary of non-face-to-face appointments over time. I think it's important to note that in August, 69% of appointments in Norfolk and Waveney, were face-to-face compared to 58 nationally. So you can see for the next set of slides that the face-to-face and the where we are offering more face-to-face appointments than nationally, and video conferencing and online appointments. Whilst there was a peak, we're now offering probably in line with national figures. And then again, you can see the telephone appointments and what's happening there. And I think that pretty much mirrors what's happening nationally. But whereas we're offering more face-to-face appointments, so that's offset by fewer telephone appointments. And I will circulate those two slides after the meeting. It's quite clear that over the past 18 months or so, that health inequalities have changed, and so different groups of patients and different individuals have been affected in different ways in terms of being able to access primary care. And we need to look at that in looking at how we resolve these problems. So what I've tried to do is to set out for you where we are now in terms of accessibility and where we think what's happening in primary care with the interdependencies. And I've highlighted some of the health inequalities, but we know there's more work to do, and PCNs are building upon the work using population health management tools that were used so successfully in looking at vaccine hesitancy. So we need to build upon that work and make sure that we're identifying those patients where a more focused approach might be needed. And of course, this will tie in with the CCG's health inequalities oversight group work that they're doing as well. So we've also, if we're going to work out whether we've been successful or we are successful in addressing access in primary care, we need to be able to have some measures and outcomes. So we've highlighted both quantitative and qualitative outcomes, and I think there needs to be more work done on the qualitative outcomes and how we can measure that. Perhaps looking at patient surveys. There's obviously a piece of work, important piece of work that we need to do with Healthwatch in helping us to understand this as well. And the appendices show the actions that we are taking, both in short and medium term. And I think it's fair to point out that obviously if we don't resolve the challenges of access in primary care, then we have patients who may not be receiving the care they need. And so it's an important piece of work for us. And then finally, I've just given you an update on the interpreting and translation services. And of course, part of this feeds into improving access for these groups of patients, for those whose language, first language is not English, and for those who use non-spoken languages. And we're working very closely with both the new suppliers of those contracts that come into effect on the 1st of November. If I can ask the committee to note the paper and to agree the actions that we're taking, and I'm happy to take any questions.
Thank you, Fiona. I'll just ask for some questions before we move to agreeing. Are there any questions for Fiona? John? You're on mute, John.
Apologies, sorry. Fiona, you highlighted the issue of looking at outcomes and looking to measure some quantifiable ones and also look at the qualitative ones as well. So just going to say it feels like there's a bit more work needed on that though. So the quantifiable ones, there's no sense of what we're aiming for, if you like, what we're looking to achieve. How will we actually know at the end of this if we've been successful or not? So it'd be good to understand what those key markers of success are that we're going to measure against. And then my other question was going to be, how much of this is being done on individual practice basis and how much is at PCN level, understanding how working more at scale can actually maybe support some different models of access or facilitating efficiencies that help practice to improve access, for instance.
If I can come back on that, so yes, we definitely need to do some more work on the quantitative and qualitative outcomes, and we'll be working with the different teams within the CCG, including the BI team and obviously our comms and engagement team, whom we're working very closely with. Sorry, John, what was your second question? Apologies.
It was the extent to which there's working amongst practices within PCNs effectively to look at how, I suppose, sharing learning, doing things differently at PCN level.
Yeah, apologies for that. Yes, I think there is work that the practices need to do themselves, but I think there's a lot of work that we can do as a system to support them through the locality teams and also at PCN level to help, particularly around understanding the challenges of different groups. I think there's work that we can do in terms of what, such as support from Training Hub to understand and educate around some of the challenges. And one of the pieces of the work that we are doing is around the Accessible Information Standard and understanding the need to make reasonable adjustments for individuals. So that's an example. So yes, it's not, it's the whole system needing to come together to provide that support and make the changes across the system and work together to make that happen.
Thanks, Fiona. Mel?
I haven't got my hand up, sorry.
Sorry. Mark?
Thank you, and apologies I was late, but I had to chair a gold call earlier unexpectedly. Hopefully that message got to you, Doris, so apologies. But just to say, to reinforce, not a question, but to reinforce a point really, I think, and it is touched on the paper, I think communication with the public is going to be critical with this. We know we've had to make changes in the way primary care has been delivered throughout the pandemic, for example, and we some of that has been liked and some of it hasn't been liked by the public, and for very understandable reasons. But I think as this work progresses, and I know it's referred to, I think it's going to be critical that we do engage, we do consult, we do have the conversations with the members of the public. I know that's part of the plan, but I think that's really more important than ever, actually, as we go on this journey.
Thank you, Mark. I think for me, actually, the glaring thing that's missing from the list is actually patient participation groups, because they're the ones who are on the ground, who can help address some of the local issues, and they know, their neighbours and their friends who might be having problems as well. Rosemary.
Thanks, Doris. That was slightly going to be my point as well about the patient participation groups, but also what exactly are you expecting practices to do, Fiona, at practice level?
Well, I think there's a range of activity at practice level that they can be thinking about. I think, first of all, from an individual patient perspective, is actually, are their doors open? Do all patients have equitable access to their services? So it's thinking about, for example, if they use intercom systems, how accessible those are, and how reasonable it is for individuals to use them, perhaps have conversations effectively in public with reception staff, and how do deaf people or those who are blind use intercom systems. So I think there's some very practical things that practices should be thinking about, but then that's supported at PCN level by looking at trying to support those practices to understand locally particular groups or areas where health inequalities or particular patients who may face particular challenges.
It's interesting with those slides, isn't it, you're showing, because in actual fact that demonstrates we are actually doing quite a lot of face-to-face work, but from the press perspective we're not doing hardly any, which is frustrating, to be fair, because we are doing a lot of the face-to-face stuff, but it's just not getting out there and getting through. The messages just aren't getting through.
Tracy?
Yeah, I think it's going back to outcomes again, so quantitative and qualitative. So me, I think Mark has said it, and also others have said it. It's about, with the population, it is how we engage, and it's how the messaging and how we kind of listening to what people are telling us, because I don't know that we're necessarily doing that enough. So generally, I don't know that people say I can't get a doctor's appointment. They actually probably can't, but it's just listening and to really understand what people are saying. So I think that's key. And I think PPGs are a good opportunity, to do that work. But it's also understanding the demand. I'm not necessarily sure that we really understand the demand and what that demand's for. So how we can match particularly what the service provision needs to be in primary care, but also what that workforce needs to be, because we know we've got, like everywhere, workforce is a huge challenge, but we've got to match the demand with the workforce, and then essentially the workforce for the future of primary care as well, because this is going to be an ongoing, I think, more longer term problem as we go forwards.
Thank you, Tracy. Peter?
Thank you. So I can't remember the name of the paper, but I feel some synergies to something we looked at 2 of these meetings ago, where we had a whole conversation around over-interpreting very high-level detail, and it links to what the last contributor was saying, that we might be doing proportionately the majority of what we used to do face-to-face. I think it's about 69% on those slides. Nationally, I'm told pre-COVID it was in the 80s, so maybe a circa 10% or so reduction. But is that the people who can persevere getting through? Is that the people most able to overcome hurdles getting through? And who are the people who are not getting their needs met today? And a similar bit of feedback to I gave when we were having the conversation previously about access is I absolutely, and obviously commission some elements in primary care as well, absolutely understand the pressure in primary care and what have you. We're very careful not to put additional pressures on ourselves. But if I was some other person reading this paper, I might perceive it to be a little bit on the sort of optimism bias front, in terms of we're very conscious of the pressure on primary care, where activity is bouncing away from other services where once it would have been met. But there is another side to that coin, which is there are activities bouncing away from primary care, applying some pressures on other bits of the system as well. And so I think, you know, for example, in the risk, it acknowledges the risk to primary care, it acknowledges the risk to patients, but you know, there is a risk to the wider system too. And finally, at the end, there's a recommendation. I'm not a voting member here, so this is just a commissioner to commissioner sort of critical friend feedback. At the end, it says that the committee is requested to consider and agree the actions. I'm not sure what the actions are. And actually, where there was just a question before around what could practices be doing, I'm not sure we have a clear answer as to what we think practices could be doing. And if we think they should be doing things, then as the commissioners, are we applying a little bit of fair and balanced scrutiny to make sure those things are happening? Because otherwise the risk is that we just trundle along and we don't pick the right, I'm not saying it's today, but we don't pick the right opportune moment to recover where we can. Thanks.
Thank you, Peter. Mel.
Thank you. Yeah, I think Peter's made some very valid points there. I just wanted, and I can see Andrew's got his hand up, and I'm sure he's going to say sort of similar to what I would say. And I think Healthwatch have a really important role here as the advocate of patients, and certainly this is why we've opted and are really keen to work with Healthwatch around a myriad of issues around, you know, patient access that we know is leading to some poor behaviour by a very small minority, but a very disruptive minority of some patients due to the messages that they're hearing. And I think, you know, that work, along with the work that the CCG are doing, that's being led by Paul, I think is really important. And I think from our perspective, you know, we want to support general practice in ensuring they're doing all that they possibly can do to improve access for some patients that are really struggling to access services, because there are key groups of patients that are struggling. You know, we've certainly heard examples of patients, you know, who cannot access a premises because the doors are locked, but they're blind, so they can't read the notice on the door that tells them they haven't been given any information about how to access the actual physical building upon arrival, and they weren't expecting doors to be closed. So I think that's really important. But this isn't every practice, and this isn't every day. It's understanding what standards, you know, are around, and how all of us can support general practice in taking stock and having the headspace and the time to look at access. So that's really where we're coming from, and we will certainly be doing our part to support practices in trying to address any problems that they've got, but doing that alongside, you know, the CCG and particularly Healthwatch, who I think really have got the patient's voice heard.
Thank you, Mel. Andrew?
Yeah, well, that's great to hear. I just wanted to provide everybody some reassurance, really, that from Healthwatch's point of view, that's exactly what we're planning on doing. Establishing the communication, really. We've got a new communications officer in post in the last couple of weeks, and working with the LMC and working with the CCG comms team, Paul and so, two Pauls, isn't it? Just a matter of interest, I had a meeting this morning. I spoke to just a random group of about 10 people, patient representative type people, and their feedback on this issue was it varied enormously between different practices. So there was a couple of people extremely pleased with the service that they were getting and the access that we were getting, and equally a couple of people who, you know, the complete opposite. Sadly, there's also several people who simply spouted the press, had read certain newspapers and believed it uncritically, and that, I think that's a difficulty. And just the only other comment I'd make is that this is nothing new. This is not, I mean, it's been made worse by COVID, but the mismatch between demand and capability in primary care has been going for many, many years. And you must realise, and you know, this is speaking personally as well, people get very tired and lose motivation, and I think that is a huge risk to our workforce at the present. From what I'm hearing when I do GP appraisals, they are very tired, and I'm sure that applies to all the other staff, not just GPs.
Thank you, Andrew. Karen?
Thank you, Doris, and I think it's been a really good conversation. I do remain concerned for primary care. Having been a mystery shopper as a user of the service the other day, I actually witnessed 2 very appalling behaviours by patients waiting to see, which was really passive aggressive, which I've never seen before in my surgery, and the poor receptionist managed it really well, and I did comment to the staff afterwards how well they did. But you know, it's this observing trend though. We seem very tolerant. I think the public, it's about comms. We need to get comms focusing, saying we are seeing people. It's taking longer. People need to be just that little bit more patient. They will be seen, but it takes a little bit longer under the constraints that we're working under at the moment. I think comms is pivotal. I don't think people realise that people are still working in the vaccination programme, that there's a huge backlog of work that people are trying to catch up with. So I think it's about trying to inform people as well. But you're seeing intolerance in life. If you go to the supermarket, I just think people are very scratchy as we've come out of lockdown, and I just think it's tragic that the workforce is really struggling with this very challenging behaviour.
Thanks, Karen. Yeah, I think it's we're not going to solve this overnight, but I think there is a bit of mismatch between data and what some people are experiencing on the ground, and some of it is probably, you know, it might be frustration that it takes 2 or 3 phone calls before they get the appointment that they think they need. I mean, that's the other thing, isn't it? It's about, you know, patients might think that's what they need, but clinically it's not appropriate. And actually, how do you send that message in an appropriate way so that they understand that they're not being disadvantaged, but actually they're being seen by somebody who actually can help them much better than seeing the GP. Not trying to, you know, be disrespectful for our GP colleagues, but sometimes others with different specialities might be more useful to the patient. But it's that messaging, and unfortunately, I think the pandemic, you know, I think we said it before, you know, it kind of, things happen so quickly that normal consultation and actually preparing people for change just couldn't happen, and we're now suffering the consequences of it. So I think keep up the good work, and hopefully things will improve with onward engagement and actually people maybe understanding a bit more about what is actually happening behind the scenes as well. And that's the bit that as patients you don't see. You know, you go into the clinic, and if you're not in the clinic, you think they're all sitting there doing nothing, which obviously is not true. So thank you very much. If there are no other questions or comments, I'll move on to the next item, which is the PCN update. I think, Fiona, you're taking this, and then we're going to move to the West Norfolk focus.
Thank you. I will be extremely brief, so that Rebecca has time to talk about the spotlight on the West locality. So taking the paper as read, the paper summarises the PCN plans for 21-22, and they are summaries. We also asked them to provide outcome. I think about the how outcomes could be measured. But in light of the updated national guidance, which took effect from the 1st of October, we'll be asking PCNs just to reflect and refresh their plans for the preparatory work that needs to happen between now and the end of the year. But I'm happy to take any questions or to move on for Rebecca to give her update.
I think you're on mute, Doris.
Sorry, well spotted. Sorry, Hein, I was talking to myself as usual. Just want to come in.
Yeah, thanks for the update, Fiona. A couple of detailed points, but in the table with activities planned by the various localities, quite interesting examples, and several that would be worth sharing across the whole geography. So for instance, Norwich is apparently preparing a video material on how GP practices are working, use of NHS app, etc. Surely that it can be used for wider consumption. Similarly, great Yarmouth, Waveney doing a pilot on GP self-assessment tool. So my general question is, I hope those opportunities are taken to that outcomes are shared widely across the geography. And one specific question is around the use of a consultancy firm in North Norfolk to support population health analysis. I hope the Director of Population Health is in the know about this. So that's one thing that stood out for me. That's it.
Yes, I mean, certainly we share the plans across the localities, so they can all see what each other is doing, and can share learning and learning with each other. I can't answer the specific question about the consultancy firm in North Norfolk, but I'll take that away and get back to you.
Thanks.
Okay, if there's no other questions, welcome to Rebecca for the West Norfolk Spotlight.
Hi Doris, thank you. You obviously had the paper and I'll take it as read. There's an awful lot of information in there. So I thought I'd just pull out some of the key hot topics that are particularly pertinent to West at the moment. I thought I'd probably start with access because I think it follows on from Fiona's paper. So in addition to the work that Fiona is working on in conjunction with locality teams, we've had a really good look at the GP patient survey. And I'm pleased to say that generally across West Norfolk, we haven't fared too badly within that survey. However, I'd like just to point out that one of the things where we did come below the CCG average was how easy it was for patients to access practice websites. So it's something we have done a bit more work looking at, and we have found that practices that are particularly using the System 1 online triage tool don't score as well. So we're doing some very particular work with those practices and those PCNs where those practices sit, as to whether now the market's opened up and there's more flexibility in choice of online triage tools, we can perhaps move to other tools that patients find easier to use. So that's very much a work in progress. The other thing I probably wanted to highlight as well is prescribing, and you'll be aware from a number of the reports regarding prescribing that there have been some particular issues in West, but I'm pleased to say that as a locality team we're working very closely with Michael and the medicines optimization team, engaging with practices. Hopefully Michael probably will be reflected in Michael's paper, but that some of the particular practices that have specific issues have some work ongoing at the moment. So we're working very closely with Coastal PCN around their use of habit forming medication, and we currently have a project jointly with Change Grow Live, and also working with the QEH about how we can support the practices in trying to reduce those medications. We all appreciate it isn't easy, but they are really making strides into those. And we've recently held meetings in conjunction with the medicines management team with our practices that have been highlighted as outliers for antibiotic prescribing, and again they've really the practices have really engaged well in that work, and that will continue. I have to mention the vaccination programme. I think obviously we've all been fairly obsessed with it, and we are still continuing with that. So all 4 of our PCNs have signed up to deliver the booster vaccinations. So we're doing that, and we're working very closely with the Queen Elizabeth Hospital in doing those vaccinations. They kindly vaccinated our child patients that are extremely clinically vulnerable. So we continue to work really closely with the QE, who obviously are running their sites from QE, and also in Downham Market. You're probably aware from last year there were some particular concerns about provision in Downham. So whilst the practices are vaccinating, QE are also doing that as well. Also LD health checks. So we have seen an increased uptake compared to this time last year with our LD health checks. We are working with NCH&C to support our practices, particularly those in Kings Lynn, with LD health checks, and we are confident that we will see increased levels from last year. We've also started a particular piece of work in which NCH&C are supporting our practices with those patients that have either haven't attended a health check for the last 3 years or have rejected one. So we're working closely, because often the patients are known to the NCH&C services, and so they're supporting us with that. I think they're the key things I wanted to highlight, but obviously I'm happy to take any questions. I'm aware there's an awful lot in there.
Thank you, Rebecca. Thank you for the report. It's very informative, and it's always good to read about progress and what's happening on the ground. So thank you for that. Are there any questions for Rebecca from the paper? Shepherd.
I just wanted to say thank you, Rebecca, for mentioning the LD annual health checks. Thank you, and for the work that you guys are doing around that. We had an opportunity to speak to the clinical directors and the practice manager. I think there is motivation and energy to see some improvements. So thank you for picking that.
Thank you, Shepherd. Hein?
Another question, really a comment to echo what you said, Doris. I found it extremely informative report. So well done to you, Rebecca, and whoever's worked on it. Thank you.
Thank you. I'll take that back.
Well, I think you've blown us away. Oh no, Karen's squeaking in.
I'm squeaking in. Just to say, Rebecca's been very modest, but the work she has done around LD and vaccination with her colleagues has been really outstanding in terms of having a bespoke offer for some of our most vulnerable people in terms of the programme. And I know that you managed some of the vaccination programme, or were part of that, with individuals with LD, where you had a separate area where it was suitable to make those reasonable adjustments. And we shouldn't forget that. That was an amazing piece of work. So well done. Thank you.
Thanks, Karen, for drawing our attention to that. Thank you to you and your team for all your hard work. And if there's no other question, we look forward to seeing you again with another sterling report.
Thank you. Thanks for your time.
Just set the bar very high.
We'll keep trying. Thank you.
Thank you.
Bye-bye.
Thanks, bye. We move on to item 11, which is the primary and secondary care interface. Lois I think it's Lois taking the paper. You've just joined us. Lovely.
Hi, Chair. Thank you. I'm not sure I want to follow Rebecca, really. I will try. So the purpose of this paper is to update the committee on data received to date from practice surveys on the interface issues, and from data received from our PID inbox, which is where practices can highlight interface issues to the CCG. So in summary, there's a wide range of issues coming out from secondary care into primary care. These range from things such as fit notes not being provided, phlebotomy requests, requests to start red hospital-only drugs, confusion over shared care, etc., etc. There were no departments that were a specific issue, and no one organisation. It's widespread from multiple individuals. There was also a perception felt from practices that the CCG isn't taking the interface seriously, and that's concerning. So what are we trying to do about it? Well, first of all, we have reviewed the current PID process for looking into interface issues. So we are now making sure we're responding to all interface issues which are flagged by practices. We are copying in the LMC where they were copied in initially, and we are getting responses back from providers, albeit sometimes slow. The themes that are identified from the PID inbox and from the practice surveys have been verbally fed back to our 3 acutes so far, and they were very open to engaging with us and working through that. However, it took a little while for them to acknowledge there were actual issues because they've just completed self-assessments of their interface contractual requirements, and is very much green, 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 because they've got policies in place to cover these things. But it took a little while to get their understanding that just having a policy in place doesn't actually mean that anyone's following it or knows about it. So I think there are issues around implementation of these policies and communication. However, they're willing to work with us, so that's great. Something positive that did come out of the discussion was QEH have taken it upon themselves to develop an interface policy, because they did acknowledge there were some gaps in policies available to support their contractual requirements, and the Paget and NNN are looking to potentially adopt that. The establishment of the interface group, which our first meeting is next week, and the initial meeting will be there really to set the tone of the group and to make sure that we're working to a positive theme, and we want to collaborate, and we want to make sure that everyone's treated as equal system partners in this. You know, it's not just primary care facing interface issues, everybody is. I've mentioned before about developing a new digital form for all of our system partners to use to raise interface issues through. I had a really constructive meeting with the LMC yesterday, and we're going to review that piece of work, because we really need to make sure that practices and our system partners are encouraged to report these issues, because it's crucial evidence for us to challenge back, and we don't want to put in place anything that's not going to work. So that's an ongoing piece of work. I'm providing an update to the clinical and care transformation group this week on the interface issues, and I will be asking for their support on moving this work forward at pace and make sure that we're actually getting traction and we can report progress back to our practices on this. Importantly, we'll be providing more communications to our practices on what we're doing about this. I think the fact that our practices are feeding back, they think we're ignoring it, they think we're not tackling it, makes it very clear that we need to be better at communicating what we are trying to do. And then hopefully we'll have some progress to report soon. I plan to provide another update to this committee after our first 3 interface group meetings. And hopefully I'll have some positive things to report back on. So that's a quick summary from me. Happy to take questions.
Thank you very much, Lois. I think that's the problem. Having a policy that sits on the shelf isn't really, you know, it's very good at gathering dust, but yeah. Actually, it's action that we require. So hopefully the interface policy doesn't end up sitting on a shelf and actually is used as well. I had a question in terms of where you're talking about on the interface group engaging with practice managers or a practice manager. Have you had any thought about whether you need sort of a practice manager from each of that feeds into each of the 3 hospitals, because their experiences might be slightly different, so you might get a better, a richer input? I mean, it's just a question, really.
I came to the conclusion that we'd go with 1 to represent all practice managers initially, and we would see how that goes. I suppose I don't want to make the group too big and start to become a bit unmanageable, but I think it's very much up for discussion if that's not working. Yeah,
it is a balancing thing between size and representation, but I'm glad you thought about it and you had an answer. Mel.
Yeah, just on that point, Lois, I'm not sure if you saw my question earlier. Again, we've been in development, of the interface with the CCG. It's actually a contractual requirement for secondary care, and those contractual requirements require the CCG to feed back to the LMC and for the LMC to feed into the action plan. There are specific contractual requirements that mean that has to happen. We were actually the executive of the LMC, who is the statutory representative body for all GPs and their practices, had offered to go on to the interface group, and we were specifically told that it was a clinician only group. So to read in today's paper, which again is the first we'd heard of it, that a PM was going to be asked to attend that group, whilst we don't have a problem with that, we think, actually that could be quite helpful, but we're just wondering why the stance has changed and why this wasn't communicated to the LMC. And as we're funded by practices and represent them, that we could have actually achieved that function for practices. I think practice managers are extremely busy and extremely yes, you are, Rosemary, I know, and are being pulled every which way, and they're not funded for these attendances. They need to be elected. We're more than happy for PMs to be elected so that they do have the appropriate remit to represent PMs, but we have made it clear in our comments to you, Lois, earlier, that we would obviously want the opportunity, if this does go through, that we would want the opportunity to work really closely with any PMs that were on the group to ensure that they are aware of all the issues, because the only organisation that's aware of all the issues, we're getting them from every single practice, 105 practices across the locality, so we have a really good overview of what the issues are relating to all three and I'm going to say all three trusts, but as we discussed yesterday, Lois, I think what's really important and shouldn't be missed is that this secondary care interface is not an acute secondary care interface, it's a secondary care interface, which means that this includes NCH&C, who have a secondary care contract, it includes NSFT, which has a secondary care contract, and we keep just talking about the three acute trusts. There are more trusts that this affects, and I know that EC isn't included on the group, but EC doesn't have a secondary care contract, so it's understanding the mechanisms for them being on the group, and I certainly think that is a really valid point, that how the three acute trusts operate are very different, but actually you've also got to look at NSFT and you've got to look at NCH&C, and you've got to have that bigger picture. So I guess we do want our question answered, because we were willing and able to send representatives to the group so that we had clinical and operational input. We have a PM liaison group who have been elected by their peers, and we've got 2 from each locality, and we fund PM practice managers to go about their work on our behalf and on the behalf of practices. And I just think you need to be really careful about putting pressure on GP staff, whether it's GPs or practice managers or any other staff. Every meeting that you ask them to attend, they're being taken away from the coalface, and they're being taken away from actually seeing patients and dealing with patients. And whilst things are important, it's important to use the right bodies to have these conversations and attend on these meetings.
So just to come back on that, Mel, thank you for your comments. Originally, we did plan that this would be a clinical only group with clinical membership, but actually off the back of some of the practice surveys and on speaking to a lot of practice managers, it was felt it would be really beneficial to have the views of that particular group represented, because they are at the coalface of a lot of this interface stuff, and they have a different view, a different perspective on things. We have a very willing practice manager who was very up for being involved in this. So I'm very, very happy to work closely with you, and also to make sure that the practice manager that we think will be involved will work closely with you on this, Mel. So I think we can make it work. I think if we encourage the practice manager to liaise with you, and plus Wendy will be sitting on the group anyway.
Thank you, Lois. Rosemary.
A couple of points. The survey obviously was tiny. I mean, only 14 practices responded. I think that's probably just indicative, frankly, of the pressure that general practice is under, that there's just not the time always to complete the survey. So the figures there are minute compared to probably what's actually happening. A bit concerned about the concept of one practice manager representing 105 practices. That's quite a big ask, and even more concerned now you said that you've got a keen and willing, in inverted commas, although that wasn't your phrase, but it's mine, tame practice manager lined up. Should the practice manager that sits on the group not be elected by the rest of the practice managers, so we've got some buy-in to who that person is?
So we haven't elected the GPs that are sitting there representing GPs, so that's not a route that we've gone down.
So
is it a case?
How do you know that your keen practice manager will accurately represent the views of all the 105 practices?
I suppose we don't, and we don't know that of any practice manager that we're sitting on that group.
No, but you might stand a better chance if there was some buy-in from other managers that was the person they were happy to be their representative.
And I'm really sorry to jump back in, Lois, but that is exactly our point. We are, our GP is elected. The LMC is an elected body, and we do have a remit to represent all GPs and their staff who are practice managers. And that's why we offered our services. And again, the first we've seen that you've changed the remit of the group, even from emails that we were being received last week, to include non-clinicians is in this PCCC paper. So it hasn't been transparent, it hasn't been discussed with us, it hasn't been mentioned, and we do have a remit to represent all 105 practices and have the expertise at our fingertips, because we have an elected practice manager liaison group and have relationships with the 105 practices, all of the managers. If we need that expertise, we've got it at our fingertips, and we can ensure that they are not overburdened and that they are fully informed of the information that's needed, and that we are, when we attend that group, and it feels that you're asking for something that's already been offered by the local medical committee that represents these individual practices. And I think Rosemary has raised a really valid point, which reiterates our point.
Thank you, Mel. I think we've heard you and we hear what you're saying. I think Mark wants to come in, and I think some of this conversation needs to be taken offline and actually sorted out. I don't think this is the forum for it, although it's interesting it's important that we hear their different points of view. Mark, do you want it to come in?
Yeah, I'll be very quick based on what you've just said there, Doris. So I absolutely hear what Rosemary and Mel have said. I think this is new. We even haven't had the first meeting yet. We've got terms of reference on the agenda for the first meeting. We are very keen that this group is a functional, effective group. I'm chair of that group, and we've done lots of discussion around the right form, the right people to invite. We don't want to cast the thousands. We want to make sure the right attendance is there. We will discuss that at the first meeting. So thank you for the comments. We'll take that on board, review, discuss, and engage on that to make sure that the group is right and functional. The other point that I was going to make prior to that was I've had several conversations now with secondary care colleagues, and that includes not just acute colleagues, of the 3 acutes, and they are very positive around this. They and Lois mentioned about the right forum and the positive discussion, the open, honest, transparent discussions in these are the issues, these are the challenges from both sides, from all sides. So I'm optimistic, accepting it's a very broad area that we're looking to seek here. And thank you, Lois, because I know it's not been an easy one to try and organise, but I'm positive around this and hopeful that when we meet again next month, we'll be able to give you a good update on how we propose to continue with this work.
Thank you, Mark. We look forward to the update, and thank you, Lois, for your paper. And no doubt there's going to be more conversations behind the scene before we come back next month. Thank you. I'm going to move the agenda on because I think we're chairing poorly. We're running quite behind time. On to the next item, which is the estates paper. Has Paul joined us?
Hi Doris, I'm here.
Hi. We take the paper as read, and any highlights or lowlights you want to draw our attention to?
Yeah, thank you. Also, I've seen the papers read. Just a couple of updates in addition to what was circulated in the paper. So under the item or section titled "Funding to Support General Practice Estate Development," we have had some feedback from practices following the message which has gone out to practices regarding the BAU process. Unsurprisingly, the disappointing feedback that's come back from practices, but we haven't had the volume that we were expecting. So in some ways, that's reassuring, and they have kind of recognised that they've still got the opportunity to bid for 2022-23 funding. The main update I wanted to just update you on was on the Way 4B schemes. So at the end of the paper, I note that we received some revised guidance from NHS England improvement regarding the approval process for the scheme. And we estimated that would take an initial 4 to 6 months to navigate that process. Since receiving that guidance, myself and Jason Hollidge met with NHS England and the Department of Health last week to go through that. And we've now got kind of a joint understanding of what they meant by that approval process when that came through. And it's looking like it's going to add a maximum 12 weeks to the process. So we're still on track to submit our programme business case in December this year, but it's looking unlikely that we'd get an approval decision on that until March or April next year. That then has a consequence to the end of the programme. So there is a risk there that we're not going to have all 5 sites operational by March 24. But the conversation we've had with the Department of Health was that there may be some mitigations around that. They were very clear that we have to spend all the NHS capital by March 2024. That's not the same as having the buildings operational by March 24. But at the same time, recognising that this is a manifesto pledge, so having like a spade in the ground is not going to be acceptable. But how far developed the scheme needs to be is to be confirmed. They have suggested they label as a round table conversation between the CCG, NHS England and the Department of Health to go through some of these issues, and they're going to set up a date for one of those in the coming weeks where we can discuss those kind of service delivery issues which impact the end of the programme. So overall, me and Jason left the meeting feeling a lot more positive on this than we were when we first got the update coming through. And I have to say that the colleagues in the Department of Health were actually really supportive about this and provided quite a lot of clarity, which was very welcome. So I'm happy to take any questions on Way 4B or any other parts of the paper.
Thank you, Paul. It's good to hear that you had some clarity. Follow that as a bombshell that was dropped. So that's good news. Mark, did you want to come in? No.
So I don't think my hand's up, Doris, unless I've left it up.
Well, it is on my machine. That's part of the problem. I think my machine's go slow this afternoon. Hein.
Yeah, thanks, Doris. I was going to make a similar point. What you just said about your meetings with the department does reassure. So when you have more clarity pursuant to those further calls, it would be good to get your read on the sort of residual risk. Before you came on, when we discussed the risk register, we were discussing this risk 15 briefly around exactly these projects. So you'll be the best guide when it's opportune to get back to this committee. But as it's a lot of money and important projects, it's good to keep finger on the pulse. Thanks.
Thank you, Hein. If there's no other questions, thank you, Paul, for the update, and we look forward to hearing from you again the next update.
Thank you.
Thanks. On to we have 2 CQC inspection reports for noting. I think Shepherd, are you taking this one?
Yes, Doris, thank you. Before I do that, can I just check that colleagues can hear me? Thumbs up if you can. Fantastic. Okay, so I've got two papers for noting, and the first one is Alexandra Creswell, Crestview surgery. The inspection was done in July, and now we've got the report published. And I just want to draw members' attention to the overall rating, then also to the individual domains. So starting with the overall rating, the surgery was rated as requires improvement overall. Then in terms of the domains that were rated as requiring improvement, so you've got the safe, effective, then the well-led section. So those are the sections that CQC requires improvements. There are two areas where the practice were rated as good. That was around caring and their ability to respond to patient needs. Suppose the final aspect I would probably want to bring to draw members' attention is what we are actually doing to support the practice to work through the improvements that are there. I think it's fair to say, as a system, we are very fortunate that we've got an experienced team within our quality team, and also within our medicines management team that are now engaged with the practice to drive those improvements that we need. I will stop there regarding this surgery and ask for questions or any comments before I move to Churchill surgery.
Are there any questions for Shepherd? I just note that on within the report, there's a comment to saying that under the long-term conditions that they've been rated as inadequate. Is that part of the work stream that we are keeping an eye on and looking for improvement?
Absolutely, that is correct, Doris.
Thank you.
Okay, so
Peter, hang on. I think Peter, have you got a question?
It wasn't not a question, but just a general thank you, actually, because Carl at the CCG kindly sort of let us know about this inadequate inspection. We do have services delivered to at the practice, and although the CQC could always reach out to us as commissioners for understandable reasons, we're often sort of forgot about. So we appreciate that that the CCG alerted us and are also looking at it from our end. Thanks very much.
Thank you, Peter. On to Churchill.
Churchill was reviewed or inspected by CQC some time back now, and they were overall rated as inadequate. And that was moving from a previous rating of being good. The areas that they were identified as inadequate were around a safe service, effectiveness, as well as the well-led domain. There were two areas that they were rated as good. That was again around caring and also the responsiveness to people's needs. This is not the first time Churchill has been brought to this committee, so I would like to probably spend a little bit more time talking about what we have done since and what we are doing and where I think we need to be. So the CCG reacted or responded quite quickly following the CQC outcome, and an intensive package was put in place to support the practice. And that package included providing just the basic project management stuff to map all the activities that we need to do and work through together with the practice. So it was hand in hand kind of type of work. And our medicines management team were actively involved and were meeting with the practice. They've got access to the practice system, they've been given that, and as well as our quality colleagues, they've been working with the practice. So that has been going on for the last 3 months now. And it was before the practice had also appointed a consultants team that the practice is paying for. So we've come to a point at the end of September where we had to take stock as to look at where we are now. And I think it is agreed that whilst we've put a lot of resources to support the practice, the progress that we have made is not where probably we think we should be. But I think in terms of, it's fair to say some progress has been made in terms of understanding the magnitude of the problem that we have and where we need to be. Having said that, the practice has submitted so far some evidence to CQC around the conditions. The first condition, which was about strengthening leadership, and also around medicines management, and also around significant events. And CQC confirmed that based on the submission that was done last week, they feel that some progress has been made, and at this point they feel assured that the practice is on the right trajectory, and they're not looking to visit the practice, or there are no immediate actions. And that information is still yet to be seen by CCG colleagues to review and form a position. But at this stage, I would say we don't recommend any immediate kind of action or escalation. I think some progress is being made, and we need to review the information that has been submitted to CQC that has provided that assurance. I will stop there for now and take any reactions or comments or any suggestion around practice.
Thank you, Shepherd. Are there any questions from anybody on this one? Karen.
Thank you, Doris. Thank you, Shepherd. I guess for me, it's about the reassurance that significant steps, I know they've made some progress, but some significant reassurance around the mitigations around their meds management and the key issues that were identified have been mitigated against. Whereas at the moment we're supporting, it's understanding that significant mitigation has taken place. So in terms of the critical meds review and a number of other things, are you assured following your last meeting that that's been sustained by the practice?
Thank you, Karen, for that. I think we haven't received the evidence in the CCG. That information has been provided to CQC, and CQC have confirmed that based on the information that they've received, they are assured, and they will forward the information to ourselves, and will review and form a view from a CCG point of view.
Thank you, Shepherd. I think this is very much, I think, beyond a watching brief on this one, because it would take a bit of time to turn around a practice that has so many issues. So thank you for that. If there's no other questions, I'm going to move on to the prescribing report. Sadie, are you taking this in Michael's place?
I will do my best. And I apologise. I think I mentioned earlier that there's sickness within the team, so they're not able to send anybody today. Given the pressure on time, Doris, would you be happy for me to take the paper as read and just see if I can answer any questions and perhaps take any away that I'm not able to answer?
No, I think that's a very good plan. Are there any questions for onward transmission to Michael? No, that was a cunning plan for Michael. We'll store it up for next month, and then he'll have double the load. So thank you for that.
Thank you.
And I hope the Meds team make a speedy recovery. So on to the final, last but not the least, the finance report. James, I assume you're taking this one?
Yep, that's right. Thank you. I'll take the report as read and just highlight the major points for this month. So on the overall summary for the Directorate, we're showing a 0.1 million adverse variance against budget for the 6 months forecast outturn. This is a significant deterioration from month 4 to month 5 position of £1.3 million. The majority of this movement sits within GP prescribing subdirectorates, where in month 5 a re-evaluation of the efficiency savings has been carried out, revising down the estimate for savings to month 6. In addition, there's continued growth in DOACs, which we've been reporting all year, and that is driving the increase in the FOT. Moving on into the COVID capacity fund, as at month 5, 2.1 million of the 2.32 has been paid out to practices, and anticipated that all of that will be paid out. Then moving into system development funding, this remains largely on plan at the moment, with only minor variances in the smaller schemes. All of the larger schemes are on plan at the moment. Moving into the delegated position, we remain with a favourable position against forecast. The volume-based APMS contract at the Norwich Walking Centre provides that favourable variance, albeit that the recent data we've had are showing that the footfall is increasing there, so will result in increased costs going into half 2. Finally, looking at GP and other prescribing, we are £1.2 million over plan in total for GP prescribing. 2 million of that coming from GP prescribing, which is being offset partly by benefits in rebates, central drugs, dressings, and oxygen. So that's the major points. Are there any questions?
Thanks, James. No, I think we've got a shaking of heads. So thank you for the update, and worrying but not surprising, the prescribing costs is increasing.
Yeah.
Thank you. I wasn't aware of any questions from the public before the meeting. Just check with Sarah that nothing's come in since we've been meeting.
No, we haven't heard anything.
Thank you. So I thank you all for the time. Slight overrun. I've kind of, yes, about 8 minutes overrun. So thank you all very much for your time this afternoon, and I hope you enjoy the rest of your day, and I will see you all again soon. And for those who are staying on for part 2, shall we have a 10-minute break and just stretch your legs and get a fresh cup of tea before we reconvene? So thank you all very much.
Thanks.